Hearing loss and ear disorders. Hearing disorders. The most common hearing disorders are those that affect the hearing sensitivity. When a sound is presented to a listener with hearing sensitivity disorder, one of two things may happen. The listener with hearing sensitivity disorder may be unable to detect the sound, or the sound will not be so loud to that listener as it would be to the listener with normal hearing. Vision is different. The most common vision disorder affects acuity, not sensitivity to the light. Acuity is the ability to resolve differences. The eyeglasses and the contact lenses improve the acuity, not the sensitivity of the light. Hearing aids are just the opposite. They improve the sensitivity to sound by amplifying it, but do not improve the acuity. This sensitive versus acuity distinction is not quite so simple with hearing or vision. Hearing loss of any significance nearly always improves the problems of both sensitivity and acuity. Sounds are harder to hear sensitivity, they may nearly always distort it. Acuity. More about this later. Audiogram is the most commonest way to measure the hearing sensitivity is the measure of pure tone or the sinusoid threshold. Threshold is the sound level required to barely detect a sound. Normal hearing, the PTA is less than 25, hearing impairment 25 to 92, deafness PTA is 92, more than 92 dB. The term deafness is reserved for the cases in which the handicap is for hearing everyday speech. Types of hearing disorder. The nature of the loss, sensitivity versus acuity. Dysacousia is a deficit in discrimination or interpretation of the sound. Don't shout, I can hear you just fine. I just can't distinguish what you are saying. Dysacousia is a good term that isn't a very common use. Acuity deficits sometimes due to disorders of the central auditory system. Disorders of sensitivity and acuity are not mutually exclusive. Functional classification could be conductive disorders involving the conduction of the sound to the cochlea, sensory-neural disorders involving the cochlea, usually the hair cells of the eighth nerve, central disorders affecting the CNS, brain stem or auditory cortex, peripheral, not central, that is conductive or sensory-neural or retrocochlear is a disorder involving the anatomical structures beyond the cochlea, that is eighth nerve, brain stem, auditory cortex. Cause The hearing disorders can be classified on the basis of the causes of disorders, for example, ototoxic drugs, noise, old age, otitis media, eight nerve tumors, and Meniere's disease. Conductive hearing loss, external ear, the congenital malformations. There are many of these. Most serious is the congenital atresia, collapse or closure of the ear canal, or external auditory meatus, may occur in isolation but typically associated with congenital malformations of the middle ear as well. Impacted wax results in a mild hearing loss easily treated by removal of the otitis media is by far the commonest cause of conductive hearing loss, and it's one of the common health problems in the children. Otitis media involves a very specific chain of events revolving around the abnormal functioning of the eustachian tube. Begins with the ordinary upper respiratory infection, head cold, involving, among the other things, the nasopharynx. The nasal secretions infect the eustachian tube. The eustachian tube, which is normally closed, becomes inflamed and can no longer open upon swallowing, yawning. This means that the pressure can no longer be equalized between the middle ear and the ambient air. Oxygen in the middle ear cavity is consumed by the ordinary metabolic processes. Ordinarily, this oxygen is resupplied to eustachian tube. With the plugged ET, it cannot occur. The absorption of the oxygen without resupply results in a partial vacuum lower than the normal pressure in middle ear. The pressure drop sucks the tympanic membrane inward the ossicular chain, resulting in its decreased mobility. Consequence is hearing loss and pain, and often quite intense. Partial vacuum creates another problem. Recall that the entire middle ear cavity is lined with mucous membrane. The pressure drop causes the clear fluid to be sucked into the mucosal lining of the middle ear. This accumulation of the fluid contributes to the conductive hearing loss. Conduction is called as the serous otitis media or the non-suppurative otitis media, defining the features clear, thin, watery fluid at that stage, and the fluid is sterile, non-infected. Suppurative or purulent otitis media, as the disease progresses, the fluid can become infected and thickens into the pus. The major consequences of otitis media are hearing loss and pain. The hearing loss is typically mild, usually 20 to 30 dB, and often fluctuating. The pain varies quite a bit but is often quite severe. It is not unusual for the pressure drop in the middle ear to become severe enough to cause the tympanic membrane to rupture. Acute versus chronic otitis media is a specific bout of otitis media with pain, accumulation of fluid, sometimes fever, etc. is called as acute otitis media. If otitis media lasts for more than 2 to 3 months, the condition is known as chronic otitis media. The recurrent otitis media, there is a frequent bouts of otitis media and is treated successfully, then returns, and this gets old after a while and pretty common. The most common treatment by far is antibiotics. The commonest treatment for recurrent chronic otitis media is PE tube, pressure equalization tube, and this is a small plastic tube inserted into the tympanic membrane. Otitis media with effusion. Otitis media is characterized by accumulation of the fluid. The mucoid or the mucous otitis media glue ear fluid in the middle ear is thick and gooey rather than thin and watery. Hearing loss is often more severe than the serous otitis media seen in some cases of recurrent otitis media. Purulent otitis media is treated, killing the infection, but fluid does not drain. Evidence is mixed and is still controversial even in many years after the study that there is some research suggesting that the frequent bouts of otitis media can result in delays in requiring speech and language. Otosclerosis begins as a soft, spongy growth of a new bone and may appear anywhere in middle ear, but most commonly near the oval window. It hardens and becomes sclerotic. There are no symptoms in 90% of the cases. Growth reduces the mobility of the stapes, causing conductive hearing loss. Otosclerosis is a progressive condition beginning in the childhood, and maximum hearing loss seldom worse, about 50 to 60 decibels. Treatment is stapedectomy. Cholesteatoma cyst that invades the middle ear, usually grows rapidly, can destroy the ossicular chain and invade the cochlea. Hearing loss usually is mild and do not relay a major concern. Cholesteatomas are benign growth in the skin in the middle ear and mastoid. These skin cysts can do cause many problems in the ear. Cholesteatoma commonly causes hearing loss and infections. The only treatment available to cure the cholesteatoma is surgery that is typically performed in tympanoplasty with or without mastoidectomy. Cholesteatoma left untreated can go and cause serious, sometimes life-threatening health problems such as meningitis or brain abscess. Cholesteatomas can develop in both children and adults. Surgery is usually done as a day case surgery. By far, the most common underlying cause is sensory-neural hearing loss is damage to the hair cell transducers. In these most common cases, the auditory nerves and central auditory pathway are intact, but the stimulation of the auditory nerve is abnormal due to the damaged hair cells. There are many possible reasons for the hair cells to become damaged. The various etiologies of sensory-neural hearing loss consist mainly of the catalog of different causes of hair cell damage. Presbycusis is hearing loss associated with aging and most common of sensory neural hearing loss. Wear earplugs or muffs when mowing the grass, snowboarding, etc. The use of some sense of listening to music. Once the hairs are damaged, they are gone for good.
One last point, presbycusis listed here under the sensory-neural category since it is clear that this is a dominant component. Sensory-neural component may not be due exclusively to the hair cell loss, changes in the elasticity of the basilar membrane, and metabolic changes in the stria vascularis may also play a role. There may also be conductive component due to the age-related changes in the mobility of the tissues in the middle ear. There is sometimes a central component due to the loss of the neurons in the central nervous system related primarily to arteriosclerosis. The result of this CNS damage is reduction in the acuity and speech perception abilities. The resulting deficit in the speech perception abilities sometimes refers to as phonemic regression, and in some cases this is the problem rather than loss of hearing sensitivity that the patient's primary complaint. Noise-induced hearing loss, acoustic trauma, and long-term noise exposure due to the intensity of the noise and length of exposure. High levels, long exposure is bad news. Low levels, brief exposure is not so bad. Ototoxic drugs. The certain drugs can cause a sensorineural hearing loss. Toxicity effects vary mild from temporary to severe and permanent. Some very common drugs are aspirin that cause hearing loss, but in most people and other loss, typically temporarily and especially important group antibiotics are notoriously ototoxic. So the list include non-steroidal drugs, antibiotic, which include aminoglycoside, amikacin, gentamicin, kanamycin, netlimycin, streptomycin, tobramycin, erythromycin, diuretics such as benroflumethiazide, bumetanide, chlorthalidone, ethacranic acid, and furosemide. Chemotherapeutic agents like bleomycin, bromocriptine, carboplatinum, cisplatin, methotrexate, vinblastine, vincristine, quinine include chloroquine and quinine, mucosal protectant like misoprostol can also cause hearing loss. So it's a common adverse effect of various drugs. Cisplatin can induce hearing loss along with nephrotoxicity, tinnitus, electrolyte abnormalities, severe nausea, vomiting, and neurotoxicity. And for the patient of the cancers, they are especially susceptible to these problems, and one has to bear in mind that metastasis can cause these problems along with the toxicity of the chemotherapeutic agent. So the problems, if there is a problem of tinnitus and the hearing loss is bilateral, then the chances is that the tumor chemotherapy has caused this problem. Other tumors which can cause uh, a loss of hearing is cerebropontine angle tumor, acoustic neuroma. They can also cause tinnitus and hearing loss. However, the brain metastases are usually found in the cerebral cortex and gray matter junction. A middle ear infection typically presents with the ear and mastoid pain, fever, and possibility of the hearing loss. If cisplatin is given, the electrolytes abnormalities can also result in toxic effect, and hearing loss results from neurotoxicity and can be damage to the cochlear hair cell as well. Immune mediated injury of the ear is common cause of acute hearing loss, autoimmune inner ear disease, and it is not associated with medication or cancer usually. Meniere's disease is a severe, often debilitating disease of hearing and balance of unknown and uncertain cause. Meniere's disease affects a single ear in about 75% of the cases. Four major symptoms are rotatory vertigo and hearing loss, tinnitus, and sensation of fullness. Rotatory vertigo, this is easily the most disruptive and debilitating symptom of the Meniere's disease,
and dramatically more severe and often accompanied by nausea, vomiting, and sweating, and typically persists for hours or even days, and the patient has little or no ability to control. Sensory-neural hearing loss is fluctuating, initially affected low frequencies. Progressive hearing may be completely lost in the affected ears, usually unilateral, and sounds may appear tinny, loudness, intolerance, and tinnitus. Sensation of fullness, like the weird sensation you get in the airplanes and the elevators before the ear pops. And the causes of Meniere's disease is approximate cause excessive fluctuating pressures, endolymphatic hydrops, and underlying cause of the fluid imbalance is not sure. Treatment, everything from diet to medication, considerable debate about the effectiveness of treatment, and the endolymphatic shunt is helpful. Vestibular nerve resection can also be offered and it has good results. Destruction of the affected ear in some severe cases, usually unilateral cases of Meniere's disease, that is unresponsive to other treatment. Complete ablation of the labyrinth is recommended. Drug therapy is beta-histine, and there have been several well-designed trials testing the effectiveness of this drug. Prognosis, according to one source, the vestibular symptoms can be controlled but not prevented in about 70% of the patient, and tinnitus seldom disappears. Infections, the bacterial or viral infections that invade the inner ear can cause sensory-neural hearing loss and disruption of the vestibular function. Other infections include mumps, measles, meningitis, encephalitis, chickenpox, influenza, syphilis, and can also invade the inner ear and cause sensory-neural hearing loss and vestibular symptoms. Eighth nerve tumor, acoustic neuroma. It's a benign non-malignant tumor that exerts the pressure on the eighth nerve, almost always slow growing, and most common symptom is the hearing loss, mild initially, often accompanied by tinnitus. The vestibular problems may also occur. Cause is unknown. The continued tumor growth can be life-threatening. Treatment is surgical removal and radiation. Early detection in early is really important. Small tumors that can be removed with less risk and destroying the eighth nerve is sometimes seventh nerve as well. Early diagnosis is tough. Congenital causes may be acquired, adventitious, hereditary, or non-hereditary. Maternal rubella or general measles is important, and when expected mother is exposed to the rubella, the mother is not in any great danger, but the fetus is expected to have first trimester, and effects include heart defects, brain damage, various visual impairments. Sensory neural hearing loss is often profound. Less commonly now, since the development of rubella vaccine, a rubella vaccine was not available when the last rubella epidemic occurred. A large proportion of the current population of congenitally deaf adults lost their hearing as a result of epidemic. Hereditary causes, genetic factors are thought to cause more than 50% of all incidents of congenital hearing loss in children. Two patterns, autosomal dominant. One pattern has dominant gene of sensory neural hearing loss. There is at least 50% probability that the child will also have hearing loss. Probability is higher in both the parents have dominant genes. Autosomal recessive, both parents typically have normal hearing, carry a recessive gene, and each child will have 1 to 4 chance of inheriting the BUM gene. Approximately 80% of inherited hearing loss is autosomal recessive. This makes the early detection tough since both the parents' hearing is normal and the children's are not considered at risk. Syndromes. The inherited hearing loss can also be associated with collections of interrelated symptoms in the form of syndrome. A few examples include Waardenburg syndrome, Treacher-Collins syndrome, and Klippel-Feil syndrome. Thank you.